Very much for the kind introduction. It's really a huge honor and pleasure for me to participate in this symposium, and thank you for the organizers for inviting me. The work that I will be sharing was partly supported by a targeted research grant on COVID-19 provided by the Eye Bank Association of America. And again, I do serve as a medical director for Eversight Eye Bank, where much of the work was conducted. As you've already heard and know, the COVID-19 pandemic is caused by the severe acute respiratory syndrome coronavirus 2, a highly infectious virus which is transmitted primarily through respiratory droplets and upon contact with infected persons. COVID-19 patients have a high viral load in the upper respiratory tract at disease onset. There's a strong possibility that the virus may contaminate the ocular surface via respiratory droplets after coughing, sneezing, and hand-to-eye contact. In January 2020, an ophthalmologist contracted COVID-19 from an asymptomatic glaucoma patient, and this was the first indication that the ocular surface may serve as a mediator of viral infection. Clinical studies, as Dr. Lee mentioned, have shown ocular manifestations and presence of the virus in tears, conjunctiva, retina, trabecular meshwork, and iris. The conjunctiva, as you saw, serves as the most common manifestation and site for presence of disease, although there's quite a huge bit of variability in the incidence and symptoms that may present in patients. Retina is also another site that has been shown to be a target where, although the patients who've presented have had normal visual acuity, OCT findings have shown hyperreflective lesions in the ganglion cell inner plexiform layers, and even cotton wool spots and microhemorrhages. The SARS-CoV-2 virus uses its spike protein to bind to angiotensin converting enzyme 2 as a receptor on human cells, along with the transmembrane protease serine type 2 protein, which acts like an enhancer to allow viral entry into host cells. The ocular surface cells of the cornea and conjunctival epithelial cells have been shown to express ACE2 and TMPRSS2. In fact, RNA sequence data in healthy human cells has shown ACE2 expression in the limbus, corneal, and conjunctival epithelium, and again, co-expression with TMPRSS2 in the superficial conjunctiva. SARS-CoV-2 can replicate in ex vivo cultures of human conjunctiva, and this replication seems to be greater than the first SARS-CoV-2 virus. Interesting study looking at risk of transmission inoculated SARS-CoV-2 in the conjunctiva of rhesus macaques. The viral load was detected in the conjunctival swab on day 1 post-inoculation and then became undetectable. The macaques went on to subsequently develop interstitial pneumonia, and post-mortem analysis revealed viral load detection in the nasolacrimal system, oral cavity, tonsils, pharynx, and lung. The hypothesis here is that the transmission is thought to be via drainage through the nasolacrimal system. So the potential for SARS-CoV-2 transmission through corneal transplant is certainly there, with SARS-CoV-2 being detected in conjunctival secretions of COVID-19 patients and SARS-CoV-2 found in ocular tissue of living, previously infected patients. Although again, there's no report of SARS-CoV-2 transmission through transplants. We wanted to systematically evaluate the presence of SARS-CoV-2 RNA and proteins in post-mortem ocular tissue of COVID-19 positive donors. The route of transmission and infiltration of the virus within the ocular tissue is still unknown, and these questions are obviously critically important to all ophthalmologists, the eye banking industry, and the field of sight restoring transplantation. When we set out to look at the prevalence of COVID-19, we wanted to look at all donors who met enrollment criteria, who were tested positive for PCR within 15 days of death. We divided them into 3 groups, looking at surgically ruled out tissues in asymptomatic cases with a positive test, symptomatic with a negative test. So these are cases where patients had symptoms as defined by the EBA screening criteria and the CDC, but either were not tested early on or were tested negative or were found to be negative through a medical director screening. We also looked at patients who are donors who were close contact with COVID-19 patients as defined by the CDC and EVA screening criteria. So in our groups here, we had 18 donors within the asymptomatic COVID-19 positive, where we looked at scleral and corneal samples in both eyes, showing a range of 11 to 17% positivity of PCR. We looked at symptomatic COVID-19 who were negative on testing. There were 13 donors with 26 specimens of sclera and cornea with a range of 12 to 15% who were positive. And we also looked at 2 donors who were close contact with COVID-19 patients, but had no symptoms and were otherwise negative. And of these 4 corneas, none of them tested PCR positive. So overall, after observing 13% of our cases where SARS-CoV-2 RNA was found in surgical to rule out tissue, our next goal was to systematically evaluate the presence of SARS-CoV-2 in different ocular layers of tissue in patients, in donors who were symptomatic as well as donor positive. We wanted to confirm that these were truly validated, and therefore we did perform nasopharyngeal swab and blood testing on all of these donors, where we did PCR for the nasopharyngeal swabs and did ELISA testing on the blood to look at IgG levels. These corneas were prepared following iBank practices, where they were the standard practice being use of povidone iodine initially, followed by PCR swab for collection of specimen. And we had a control group for the other eye where we did this without the use of the povidone iodine to see what the benefit of povidone iodine was in these cases. Of course, then we also wanted to confirm looking at spike and envelope protein with immunostaining in a sample of these specimens. So we had 10 symptomatic COVID positive donors that we tested. As you can see here, they were all pre-mortem COVID-19 test positive. The range of time to death and testing to time to death is listed here, and there was a wide range between 1 and 15 days. Of these, 6 out of the 10 were PCR positive from their nasopharyngeal swabs, 4 were negative, and 8 out of the 10 were IgG positive on their serology testing. All 10 specimens were at least positive in one of the 2 postmortem tests, either PCR or on the IgG testing. The 2 that were IgG negative may have been because they were too early in the course of their disease to be IgG positive. When we looked at our specimens for positivity, because we're looking at different layers, all 20 eyes, 3 conjunctival, 1 anterior cornea, 5 posterior cornea, and 3 vitreous swabs tested positive for SARS-CoV-2, exhibiting a positivity rate of 15% in the conjunctiva, 5% for the anterior corneal surface, 25% for posterior corneal surface, and 15% in the vitreous. We wanted to do further testing to look at immunostaining, looking for the spike in envelope protein within the specimens tested. And for that, we we'd had a control group with the antibody control using a non-COVID-2 antibody and a healthy control where we knew that the donor did not have COVID to look for, again, both the envelope and spike proteins. You can see in the bottom right corner that the corneal surface was positive for viral antigen for the envelope protein, and the same specimen in the bottom right corner was positive for surface for the spike protein on the corneal surface. When we did this with specimens that were treated with povidone iodine, none of the surface specimens were positive for spike or envelope protein. So the impact of postmortem testing was also something that we wanted to look at to explore the utility of routine postmortem testing of all potential donors. In order to do that, we performed postmortem COVID-19 testing in all donors which were intended for surgical use. This included 505 donors that were identified for surgical use through EBA iBank eligibility criteria. Of these, 60 donors were not procured for other reasons than COVID rule-outs. 126 of these had pre-mortem nasopharyngeal swabs performed at the hospital or the organ procurement organization. 48 received post-mortem nasopharyngeal swabs performed by the organ procurement organization, and 266 had testing done through the eye bank itself. Of these, 15 tested positive for a percentage of 4.2%. When we look at these 15 cases, none of them had any obvious symptoms, chest x-ray findings that were consistent with EVA criteria and CDC recommendations. Several of these were also reviewed by medical directors and were deemed to be surgically usable. The 3 that are highlighted here that were not used were because these were found to later have reasons not to be released, such as positive serology testing or other historical findings that were not earlier identified. In summary, our findings suggest that there is a small but noteworthy prevalence of SARS-CoV-2 in the ocular tissue of the donors that died from COVID-19 or had related signs and symptoms. Post-mortem testing reduced eligible donors by about 4.2%, and of these, 3.7% were through the eye bank testing. This highlights the importance of donor screening guidelines as set forth by the EBAA and FDA and CDC. Post-mortem nasopharyngeal PCR testing does have a role to consider to identify donors that may still be positive despite the strict screening criteria. And continuation of infection prevention protocols using povidone iodine is useful for prevention of transmission of COVID SARS-CoV-2. I'd like to thank all our collaborators at the eye bank, Wayne State University, and Rush University in conducting our work. Thank you.